you to this extremely critical plenary of this conference. The theme of this plenary is equity in access to palliative care in India. And our chairperson is Mrs. Harmala Gupta. She is a cancer survivor. In 1990, she started the first cancer support group in India, Cancer Support. We all know about this group. She's also the founder, president of Cancer Care India, a network of cancer support organizations in India and around. Over to you, Dr. Gupta.
Thank you, Dr. Anjum. Well, as you rightly said, we're all looking forward to this session. And I don't want to stand between, between the speakers and those who are watching. So let me just begin with the introductions. We are going to start with Dr. Sushma Bhatnagar, followed by Dr. Pavanendra Lal. And then, of course, the keynote speaker is Dr. V.K. Paul. But to just tell you about Dr. Sushma Bhatnagar, she has a slew of honors. I shan't read them all because then we'll never finish. Suffice it to say that she's head of onco anesthesia, pain and palliative medicine at the Institute Rotary Cancer Hospital and NCI in AIIMS, New Delhi. She's also chairperson of COVID services at the NCI in Jhajjar, AIIMS. And she is one of the persons who has really been promoting palliative care around the country in her capacity as president of the Indian Association of Palliative Care, to which she has been recently re-elected. Moving on, I'd like to introduce Dr. Professor Pavanendra Lal. He is head of surgery and chairman division of minimal access surgery. He's affiliated with Maulana Azad Medical College, New Delhi, and he has a number of firsts to his credit. He started the fellowship in minimum access surgery under the National Board of Education, and that has started since 2011, and along with metabolic surgery, OPD. And I know that he's played a very important role in starting the DNB in palliative.
Is basically to hear, we want to hear Professor Paul, that what exactly the way he has supported us and what exactly the government policy should be. So before sir will start speaking, we will just like to brief that what exactly we are already doing in the country, and from where sir will tell us that how should we speak, and then Professor Lal will speak. So I will speak as a president Indian Association of Palliative Care and also as a head of the palliative medicine at AIIMS. So what are the various activities which we have already done? I'll finish in 10 minutes. That the activities which we have done is to teach and train doctors, nurses, volunteers, physiotherapists, pharmacists. We have also done through Indian Association of Palliative Care ECO program, so that all our doctors and nurses should be well versed. We have done in the COVID wave 2 webinar on advanced active, and there are a lot of upcoming courses. So first, I will say that when everybody was shocked to see the COVID wave and all the academic activities they stopped, but IAPC has continued the academic activity, and I should say that they have done a lot in the COVID period also. So right from the week starting on Monday, we had a lecture, IAPC academic lecture series, which starts on Monday, every Monday, 6:30 to 7:30. And before 6:30, almost 150 people already, every Monday they join. So we have finished first, second, and third series. So that this purpose of this series was that we wanted to remain connected, and we wanted to update the recent advancement in palliative medicine to all our young palliative care physician all over country. So all over country people are joining, and series 4 is starting on February 14th, which will concentrate only on the clinical pharmacology of various drugs which we are using in palliative medicine. This is in the planning stage to provide fellowship in palliative medicine, so that a doctor, non-medical institution doctors, those who are already practicing palliative care, they can get a confidence. The third thing which we have started, in 2007, and I'm really proud of this program, that is certificate course in essentials of palliative care. This program is for doctors and nurses, and in COVID, everyone was again stopped all the academic activities. But what we have done, because this program we were conducting almost through 47 centers in India, what we have done, we have started conducting this program online. So all 47 centers people were joining, and you can see that almost in July 2020, December 2020, July 21, and January 2020, we have almost trained 400, more than 400, 2000 healthcare workers by all these four programs. And total number of professional trained till now, doctors almost 5,970, and nurses we have trained are 3,333 from all over India. Eco Series was again a very important program, which was basically uh, coordinated by Dr. Gayatri, Dr. Megan, and Dr. Spandana. This was supported by Hyderabad Cancer of Palliative Care and Two World Cancer Collaboration, and this was a real success of giving the basics about COVID-19, which everybody should have known. And all these recordings are available on IAPC website. Similarly, IAPC academic lectures are also, all 74 lectures till now are available on IAPC website. So any member, if they want to, they must have missed any lecture, they can see this program. It's always remain a problem that communication and teaching psychosocial aspect of taking care of a patient. So Dr. Seema Rao and Dr. Ganpati has taken the lead, and they are excellent. It is also important to teach uniform skills to physiotherapists, that what exactly they should do when patient is in the end stage of the disease. For this, we have started physiotherapy program for all over countries, physiotherapists, those who are looking after palliative care patients. And this program is led by Dr. Kalpana Balakrishnan, and first batch is over and second batch is third. The program is volunteers training program, because it's the development of palliative care has happened in last 4 decades, and first 3 decades were basically NGO based, and a lot of work was going on at the volunteers level, which is also still going on. So we think that volunteers should also get trained, and this program is also going on very well. And Mr. Radhakrishnan, Mr. K.M. Nuruddin, and Dr. K.V. Ganapati, they are looking after this program. So this is also again a uniform teaching all over India to all our volunteers. This is the advanced directive, because a lot of youngsters remain confused what exactly it is. So we do a lot of webinars, and this webinar was the most effective webinar. It is again available on IAPC website. This was the experts were Dr. Roop, Dr. Mani, and Dr. Sima. Upcoming program, which I want to say, that because a lot of pharmacists, they are using opioids, but they don't know how to procure, how to store, and how to dispense. If you ask any pharmacist, they are not knowing the recent amendment of NDPS Act. So we have started a uniform teaching program for pharmacists for whole of the country, and the first batch will be starting on 27th February. And I have heard that already we have crossed our registration, so we have to do the second batch very, very soon. For gynae oncology, recently Dr. Nirja Batla, who is heading the department of gynae oncology as well as the president of Gynae Oncology Society, she asked me to develop a module for a module of palliative care for gynae oncologists, and we have developed, and Dr. Rajashri is leading that program. And we are going to start very soon, as in the next month onwards. Similarly, we are also starting a specialist intervention in palliative care program. So, and this is a very important program because we consider that nurses are the biggest backbone of any system, and we always underestimate their power. If we will teach and train our nurses, I think any program can be successful. So we have started and educating our nurses all over country through LNEC program. This program is led by Sister Hanife, but there are many nurses from India. They are teachers in this program and they are leading the show. And almost all over country, they have already trained. And in AIMS, I'm really proud that almost more than 600 nurses are trained, and more than 100 nurses are already teachers of palliative care. So see, all these, you can see that various parts of country they have reached and they have trained the program. Yesterday they were in Jaipur in Mahatma Gandhi Hospital, and the program was really hit program. To develop this was on the this was one aspect, but it was also important that in 2012 Medical Council of India has recognized palliative medicine, but institute based palliative medicine was not developing at all. So we have started to develop this program, and we wanted, with this program, this was a joint initiative of AIMS and Asia Pacific Hospice Network, as a part of Lion Collaborative. We started in 2016 with the 4 objectives that we will develop capacity building in the institutions, we will make opioids available, and we will teach how to use it safely. We will educate that institution particularly, and we will start advocacy program in that institution and around. This was a program of 19 days teaching over a period of 1 year. We have enrolled 10 centers in this program in 2016. We were successful in 5 centers. The key findings we found failure continuously was that lack of motivation amongst the trainers is the trainers which we have chose was wrong. So what we did in CTC2, we enrolled 9 centers and 8 hospitals, and you can see all AIMS Jodhpur, AIMS Patna, AIMS Rishikesh. I'm really proud that they have all AIMS have now dedicated palliative care program in the AIMS through this CTC program. And the key factors of successful success was again the selection of the champions. So the champions were on the senior role, and they wanted to develop the program. And there we also started on-site mentoring and training, so that there was continuous follow-up over a period of 1 year. So this program was over a period of 1 year and with the constant follow-up. With CTC3, we have enrolled 12 centers and we have been successful in 10 centers. In CTC4, we have enrolled 17 centers and the program is still going on. Total number of centers institutions already have dedicated palliative care program 23. Palliative care OPDs have increased, morphine availability has increased, and these 4 important contribution which AIMS has given, that recently it has recognized as WHO collaborating center. So this opens our avenue to teach and train more doctors and nurses. And I'm really proud that in 2012 MD palliative medicine was recognized. We could start only in 3 centers, but in this year only we have started in 3 SMS Medical College Jaipur, KMC Manipal, and Mahatma Gandhi Medical College Jaipur. So there are already, we will be having 7 or 8 MD palliative medicine seats, and 5 institutions have started DNP program with the help of Dr. Lal. And this is my last slide, that we all as a IAPC membership, all the faculty members all over country, they are really working hard voluntarily. They are giving their time to develop capacity all over country, because it was a new subject, but now it is no more new, and everyone is working hard, and they have taken an oath that we will continue to work hard till we reach to every patient who is suffering with serious health related disorders. Our aim will remain to assess what exactly available, to develop the centers, implement whatever policies we have made, and the best part of our program is we make uniform policy all over country, which can be a sustainable program. Thank you very much.
Thank you, Dr. Sushma Bhatnagar. Moving on, I now invite Dr. Professor Pavanendra Lal to speak on his topic, which is the initiatives taken by the National Board of Examination in the past few years. Dr. Lal, over to you.
A very good evening to all of you, and thank you for this very kind invitation. Greetings to Professor Paul, Member Niti Aayog, Dr. Sushma Bhatnagar, Professor and Head of Palliative Medicine at AIIMS, and the President of the Indian Association of Palliative Care, chairpersons, moderators, faculty members, delegates, ladies and gentlemen. At the outset, I would like to be very pleased about the fact that we at the National Board in the past 2 years were able to contribute effectively to the advancement of education and training in palliative care medicine. And my short presentation is just to make a little bit of awareness amongst the delegates here about what we are and what we did. So my tenure in the National Board started almost with the COVID in April 2020, and I exited there some while the country was battling very effectively led, and with the policy decisions that were coming. National Board is an institution. I had the opportunity to serve for about 20-month period. It's an autonomous organization established by the Ministry of Health and Family Welfare in 1982, and an assessment. We conduct postgraduate and the entire network of private hospitals, which are inclusive of the specialty DR fellowship courses, which are the F&B. Of the by Professor Paul in the country that is capable of providing teaching and training should be optimally utilized. My mind when I was there during this information of everyone, we conduct a lot of prominent of which are the NEET postgraduate and the NEET super specialty exit examinations for almost 1,75,000 students appeared in which would be for the current counseling that is just going on. These are the 4 types of basic specialty and the fellowship courses. One after the broad specialty and one which are after the super specialty. Paradigm achievement that we were able to do in the last 20 months of the COVID years, BS diploma courses throughout, and I'm very to say that in the very first year, more than the entire country in this diploma had disappeared because the Medical Council of 3-year degree course, not because diplomas are inferior, because the Medical Council would like to have more teachers, and the diploma holders are not considered as teachers. So we had a space which was available in sync with the ministry, was able to do these, start these diploma courses, and they are also being processed through the current NEET PG entrance. But what is important here is the story. And we received the request in the mid of, and it was the indulgence of Professor Bhatnagar that she spoke and wrote in detail and told us that the program is currently running, which was started in almost 2011, has not been utilized in the huge potential that we have across the country through the National Board of Examination accredited institutions. So with several meetings, a specialty board was constituted in the month of September 2020, and we had multiple meetings for the draft of the course and the curriculum. And I must again say that the specialty board had done a lot of its homework change in the country through the All India Institute of Medical Sciences and the courses that were going on elsewhere in the country. And finally, the course was approved by the governing body of the National Board of Examinations in the month of December. And the application was launched in the month of January 2020. You can see it was all during the first and the second wave. We did a very rapid accreditation process because we were targeting the 2021 admission. And I think this is historic because this has not happened so fast ever in the history of any course with any, either with any controlling authority. But with God's grace, we were able to do the, we had about 10 applications, but ultimately with the accreditation being provided to 5 centers with the 2 seats each, we were able to release 10 seats for the counseling process in the month of September to the Medical Counseling Committee of the Government of India. And finally, I think the new entrants would be able to see the fruit of this labor in form of admissions, which are happening in the current months of January and February 2022, which is actually the NEET PG of 2021. So I think I'm very pleased that with the indulgence of the faculty, which very motivated faculty, we will be able to support the teaching and training in palliative medicine, which is a much needed subject. And it has its presence in the entire country because cancer being a disease which has such a large numbers, and the care of the advanced malignancies and those who are requiring palliative care is also increasing in numbers. There is no doubt that this is a course which needed to be there. It has come in exactly 10 years after the MD in palliative medicine, but it has come in, and I'm very pleased that I was able to do my little bit while I was there in this institution. And I must thank the entire faculty who supported the entire governing body of the National Board, which was also in sync with the whole idea that this was a felt need. And also the entire faculty who visited the centers for accreditation during the times of COVID, because they were very keen that this course starts at the earliest. And also the dream of Professor Paul from the Niti Aayog that we try to optimize every possible bed and every possible opportunity in the private sector and convert it into a training and a teaching bed. And with that, I think we have been able to add 10, and I'm sure many more seats would be added now, since the process has already started, and more centers would be keen for the application for the same. And this branch is going to find more number of students who would be encouraged to take this as a career option, with the need, because the course is limited in number, the need is very large, and so this will be a very popular course amongst the students, and this would increase the effective management of the patients requiring palliative care. So with that, thank you very much once again to Dr. Sushma Bhatnagar and to the chairpersons for this opportunity to present the opportunity that I had to contribute to the start of the DNB palliative medicine while my tenure at the National Board of Examinations and Medical Sciences. And I wish this great success in all these endeavors, Dr. Bhatnagar. Thank you very much.
Thank you, Dr. Lal. I think whole community, palliative care community, is really grateful that the way we have done the work during the COVID time with you and the support from. I think I cannot forget that I have sent a letter to Dr. Professor Paul that, sir, already MD palliative medicine is started in 2012 and we could start only in 3 centers. Please support our program. And I think in the governing body, sir has supported this program, and you cleared in the same meeting. And I can't forget the way you all have supported our program, and I'm really happy. So now the time is, thank you very much, Dr. Lal. Now the time is to listen, Professor Paul. The whole India is waiting to hear you, sir. And I'm really privileged and honored to introduce. Anjum has asked me to introduce, and I'm really happy because this is such a great honor to introduce, sir. We all know that as the youngster and as when we are doing our MBBS, we all have grown up by starting and reading your books in pediatrics. But I would like to start with that Professor Paul served on the faculty of Department of Pediatrics, All India Institute of Medical Sciences, New Delhi, almost for 3.5 decades, and was head of the department for nearly a decade. Dr. Paul is globally recognized medical scientist and a public health exponent. With the quality which sir was having, Government of India appointed Dr. Paul as a member in the rank of Union Ministers of State of National Institution of Transforming India, the Niti Aayog, the famous Niti Aayog, in 2017. And suddenly we came to know that sir has gone to Niti Aayog, where he lives, but he went there and he did wonders over there also. He led the health, nutrition and education verticals. He has played a pivotal role in formulating the Ayushman Bharat Health and Wellness Center scheme and Poshan Abhiyan. Professor Paul also served as a chairman of the Board of Governors in Suppression of Medical Council of India in 2018 to 2020. This tenure was recognized for the record increase in number of undergraduate and postgraduate seats and introduction of telemedicine guidelines, district residency scheme, and plethora of other reforms. So Medical Council of India, the major reforms has happened in his tenures. Dr. Paul is a part of core team of Union government for COVID-19, and you must have seen Dr. Paul many times on TV. Many times his articles were coming, his messages were coming for all of us when we were struggling and we were fighting with COVID-19 pandemic. So he was the major support and major team members from Government of India. He chairs the Empowered Group of Emergency Management Plan and Strategies, Empowered Group of Vaccination, and National Task Force on COVID-19, as well as National Expert Group of Vaccine Administration for COVID-19. And today only we have read Professor Paul has given us his opinion about vaccination under 16 and probably after the expert group result, sir will tell you that expert group result whether we will be able to get vaccine for under 18 also. Professor Paul has over 400 scientific publications and H index is 62 to his credit. He featured amongst the world top 2 scientists in the field of pediatrics according to a study conducted at Stanford University in 2020. He is a fellow of all the 3 science academy of country and recipient of preeminent Dr. B.R. Ambedkar Sanitary Award for Centenary Award for Excellence in Biomedical Research by Indian Council of Medical Research. Dr. Paul has conferred with the prestigious Hassan Demography Family Health Foundation Prize by WHO at 2018 World Health Assembly by his globally recognized service in field of family health. He supported palliative care program at every level, including DNB palliative care program, and he supported all of us. And on personal level, I just want to say one more sentence, that whenever we are in trouble, if we call or we send an SMS to Professor Paul, even if at 12 in the midnight, he will definitely answer and he will try to solve the problem. This much power sir has, and we really want that, and we want to hear you, sir, and we want that you should keep on giving us strength and you always remain happy and healthy, sir. Thank you, sir.
Thank you, Sushma. It was a very longish introduction. Thank you very much for your affection and friendship and professional partnership. Madam Harmala Gupta ji, Dr. Pavnindra Lal ji, Sushma, distinguished leadership of palliative care in India, participants of this meeting, thank you very much for giving me an opportunity to speak to the palliative care community and family of India. I'm really honored. I have been involved with child health, newborn health, maternal health, and moved on to some policy areas across other sectors and priorities in communicable disease and non-communicable disease. But today, it's really for the first time that I'm face to face with a very special community, the palliative care community and the family. And it makes me heartwarmed because you deal with relief of pain, you deal with very, very human issues. You help the families, you are humble, you are caring, and you are alleviating pain above all. So I salute you and I salute your work. And I'm honored that I'm really formally interacting with you, and goes without saying that we are partners in this journey together. We are comrade in arms, we are fellow travelers. I compliment Sushma for her work, her thinking, her foresight, her vision. And I do keep cajoling her that your ideas have to fit into the health system paradigm. And I'll try to bring those some issues very briefly in front of you. So I tell her that your forte is education, clinical, care and research. But when you want it to be taken to scale, there is other work to be done. I'm very happy to see that the Indian Association of Palliative Care and your leaders, including Dr. Bhatnagar, have done tremendous work in the field of teaching, training, education. Remarkable. It's very focused. It's very deep. It's also multidimensional because you're looking at nurses, you're looking at institutions, you're looking at doctors, and you're looking at formal course. And I think having a formal course, whether it is MD or DNB, is a very important high point because that gives identity to a specialty. And that is therefore very critical that Dr. Pavnindra, you ensured that the second track of training, namely through the National Board of Examination system, is working, is functioning, and a big start has been made. So really compliment you on this. We must remember that, sorry. The first point that comes to my mind, impromptu. I'll come to my thought out points later, is the following. Remember, in one go, we try to go in the direction of specialties, and that's how it grows. The science grows, the expertise grows, the specialty grows. But you must remember that something like palliative care, something like newborn care, child care, cannot be delivered only by the specialist. It must not be delivered by specialists. It has to be brought to simpler level of application. And never forget that. You see, neonatology is a super specialty, not even specialty, super specialty. World over, we didn't do it. It is seen to be a super specialty within pediatrics. But when it comes to improving newborn health, then there is a role for an ASHA worker to breastfeed, to help look after low birth weight baby, identify problems. For that matter, in pediatric, which is a specialty, to look after diarrheal disease, provide counseling for food, pneumonia, vaccination, fever. So, and very often the messages are the same. The prescription that ASHA worker will write for diarrheal disease, continue food and continue drinking, ORS, zinc, danger sign, is exactly what I write for my patient. The principle, the code doesn't change. But then there is room for a lot of work at different levels of healthcare system and providers, and at the same time, at the high end, the most sophisticated form of care through that specialty. And I would urge you that we will always bear this in mind. But let me go back to the fact that the palliative care deals with prevention and relief of suffering. I think within the medical sciences, medical care, profound word, dealing with prevention and relief of suffering. What, in some sense, it is at the highest pedestal, this thinking. And this suffering of the patient and the family could be due to physical illness, but never forget, and I will not like to forget, it could be due to mental health issues. And the pain and suffering could be due to mental health issues. And therefore, WHO encompasses not only physical, but psychological, social, and even spiritual suffering in the ambit of palliative care. And that's a very, very aspirational vision of the leadership of palliative care in the world. Then there are three principles I see that define palliative care paradigm. Firstly, it is integrated with other forms of care and support. It's never in isolation. It must not be seen in isolation. And therefore, a palliative care community or a professional or a provider is not working in isolation. She or he is always working as a partner, because there is an underlying disease. There are complications, there are disabilities. So one thing that defines the characteristic of palliative care is always there are other people in the team. It applies actually to most settings, but then I think for this one, it couldn't be clearer on principle. The second is that palliative care, the heart of palliative care is the family setting. Palliative care happens in the milieu of the family. Everything happens in the milieu of the family. But just think about, alleviating suffering, pain, near-end decisions. Family is the milieu. Without engagement of the family, very difficult decisions on the part of the family. How do you impart this great relief and alleviation of pain and ill health? And that therefore makes you special. And the third one is, and which I will elaborate a little bit more, is that it is applicable as a care paradigm at all the levels. And that connects to my first premise that there is a high end, and then there is the most simple but most widely applicable end. So it's at all levels. It is not cardiac surgery only in the tertiary care. Okay, and it is therefore like child health, maternal health at all levels in its own way. So these are the three characteristics which I find are unique and inseparable as for the care paradigm as well as a specialty. Having said that, it is evident that we are dealing with huge unmet need in this area. And that is what brings us together, a policymaker, policy enabler, and you all, and your pain and advocacy effort that this unmet need should be met. That's the pain that I see on the face of the community. Nirmala ji, Sushma ji, others. कैसे पूरा कर सकते हैं? It is estimated that globally 40 million, 4 crore people every year need palliative care. I don't know what your estimates for India every year are, but it could be and should be perhaps close to about 6 to 7 million per year. How many of them are receiving minimal palliative care? Then you get the gap. So I want you to start thinking about this, because when next time you visit a person like me, you will say, hey, forgot about this unmet need. You put the human individual dimension to say how painful it is. But then if we have to work through the public health pathways, then we have to ask this question: how to address this unmet need? What is the quantum of that unmet need? The characteristics of this unmet need. What I know from my little knowledge is that the conditions, there's always an underlying condition. And these conditions in adults are cardiovascular disease, of course, cancer, I think above all, I should start with that, chronic respiratory disease, chronic renal disease, and HIV, I guess, and so on. Indeed. And in pediatric age group, I guess it is about malformations and I'm told heart disease, cancer, etc. So this is the underpinning on which this occurs. And there could be other disorders. Someday you can guide me more, give me a presentation on the dimensions of palliative care in that sense. You very rightly put the action to address is through assess, develop, implement, and sustain. I like that paradigm. And we like you to develop this idea further for people to be engaged. Now, I like to now pursue this and try to see the levels of care that where it is needed. Above all, the most important level is the home level. Let me start from there. And people like, esteemed colleagues who have been in this field would know that ultimately home has to be the delivery point. And that's unique for you because some specialties don't talk about home care. My specialty talks about home-based newborn care, child care, child development. But the orthopedics people, do they talk about home care? I'm not sure. Plastic surgeons, I'm not sure. Okay, but certainly palliative care, the ultimate core is the home, which means you have to think like that. How would this reach in home? What are the tools that will take this dimension of care to home setting? Who will provide? And in some sense, there are some interesting lessons from COVID, because a lot of COVID was handled at home. We were not doing very well in the early phase, but by the time we had, the second surge, home care was mastered by most states. There were messaging coming at home, kits were being delivered, people were visiting, tests were being at home. And the recent surge, my colleagues tell me, and I can name here Dr. Acharya, whom you know, Sushma. He said, मेरे को इतने फोन आ रहे हैं, 4 बार ही फोन आता, आप ठीक हैं, आपको ये है कि we mastered it, right? Telehealth helped us, connect with facility helped us, sending a kit helped us, sending medicines helped us, sending Ayush medicine. These were some of the tools that worked. There must be many more. There must be more that could have been done, should have been done. But the point I'm making is, think about this home delivery of palliative care. And here, if I would forget, but I want you to remember also, and it could come as a separate point, but I don't want to miss my thought. And that is, think about the Ayush system and Ayurveda as a part of this. I would like this to be noted very carefully. We can talk about it. I can put you in touch with those people, because when it comes to home, facilities we may be separate, but in the home, we can have an integrated system without having to impinge on any law the families accept. So one is paradigm at home, family at the center, caregivers at the center, humane, supported through telehealth, supported through other means, NGOs, communities, providers, visiting. Think about how you will build that. This is not only for the rich, for the poor. It's not an apology. It's actually for everybody. Because after a point, you leave the hospital, you go home. In fact, it's also industry. If people are hearing me, it could be something that a startup can start with tomorrow. Can be done. Create that pathway. And of course, when I'm saying this, I am also thinking how it can be done in the public health system and help us do that. Then comes the next level, which is the primary healthcare level. Then I want you to think very carefully about it. We have a health and wellness center, which is the platform for primary healthcare, both in the rural areas as well as in the urban areas. We are building 150,000, 1.5 lakh health and wellness centers. We have completed almost 90,000, 85,000 or so. These will be completed by the end of this year, which is the 75th year of India's independence. Completing. This is how it was targeted. Part of Ayushman Bharat, pillar number 2. Pillar number 1 being the more famous Pradhan Mantri Jan Arogya Yojana. It is committed that there will be one care pathway is palliative care. Build on that. You have an example where it has been developed. I keep telling Sushma, create that model. Test it in Ballabgarh, which is the extension site. Make it work. When I say test it means, what do you need? What are the building blocks of this? What is the package? Who will deliver it? How will you train the person who will deliver it? How will you supervise and ensure delivery in a predictable way in that catchment area where everybody needs it? How will you monitor it? How will you support it? And in case, the way I mentioned, how do you support home level care? How do you connect it to the care that you will periodically give at a health and wellness center equivalent site, which could also be a primary health center tomorrow? So we need to think about how to build it into the health and wellness center, a scalable, sustainable model, which will be relatively simple, straightforward, doable by the frontline worker. So I like to hear your ideas on that. I like to hear your academia to test it. Can we test it in 3 AIMS, 6 AIMS in their tehsil, sub-district sites? That's what is needed. I don't have a model that I'm aware of in the public health system. So home connected with PHC is the model waiting to be developed. It is a job of academia. It is a job, academia with the help of NGOs, with government. Do it somewhere, demonstrate it. And I know in our country, we have interest and evaluate what's already available. Kerala and Thailand. Kerala, we have an example of 1,000 PHCs where trained people are there. I don't know how well it is working. Bring that up, share, systematically study. That is how you build a momentum for introducing new aspects. So also, I believe a similar primary care model exists in Thailand. Read about it, learn about it, and help us develop primary healthcare driven, primary healthcare supported, home-based palliative care. At times, of course, home care can bypass the primary care on a daily basis, but you always need a primary care hub because you can reach with services directly to home, and therefore I try to put the home separate. Having said that, third level is the facility, the familiar facility level, both government and private. You have made tremendous progress in that. You got sites starting the palliative care system. I like you to continue to push this. I like you to think about in-hospital, hospice care type of a paradigm as we move forward. I know you have this, you know it, and try to build on that, try to get traction for people to access this healthcare, which is very important. But I also don't want you to forget the private sector. Are we easy to reach in a way, easy to create momentum in a way, but you create those pathways for providing care at the private healthcare system, and of course, education, as Pavindra mentioned. So this is one part. I'm trying to think of 3 levels: facility, primary healthcare nodes, urban, rural, create the model, NGO community, Harmalaji, your colleagues can help us develop it. We can help you. We can help academia who will take it forward. You need to get getting people excited about this from the community medicine department, because they are the ones who are familiar. Often the palliative care anesthesia community are not really strong in their presence. But we have to learn this art. We learn that art. Okay, cardiovascular community has learned this art. And they brought community cardiology. People like Dr. Reddy brought community cardiology. They went to the field. We have to go to the field. Who would imagine a cardiologist of the 80s to think about, public health approach to cardiology? Today it is at the center stage, right? So kindly, therefore, demystify. That's one direction to go. Now comes the point with regard to other 3 or 4 aspects. The first one is the access to medicines. Here I would like to know, are there any policy issues which impede access to some medicine? I think there are. I don't want to go into details here, but let's discuss that. Can we change those rules? Do we need to change those rules? Or do we need to create other pathways? Which buttons have to be pressed? Is it about the NMC Act, or is it about some other Drug and Cosmetics Act? Or is it only some executive notification to be done? So that is something. Which drugs? At what level? Have you decided? Which drugs are you thinking about? Which one can be given to in the hands of everybody? Is that person entitled or not entitled? Are the mid-level provider of today, can she write this particular medicine? Then we have to enable her. And then, of course, supply side of ensuring these medicines, both in the private sector, the primary care system, the district and the sub-district hospital system. By the way, when I said facilities, obviously a very important hub will be a sub-district hospital and a district hospital, private sector hospitals and nursing homes. Just not look at hospitals, but also medium-sized nursing homes, even individual doctors. Why not? Why not? If you're dealing with alleviation of suffering, then individual doctors have a role to play. So that's why, a cross-cutting area that you kindly help us think through. The next issue is back to education. And here I would urge you, and you have already done work in this area, is to expand to nursing. And in-service training is one part, but formal training and creating that critical mass and demystifying again is very important. And you may have to try some tricks how to get people to do that. Which nurses will come forward for this? And here in the education space, there is a fault that we need to correct, and that is all of us. What about the palliative care as an element in undergraduate education, but also in the education of pediatricians, cardiologists? Maybe the cancer specialists are learning it somewhere. I didn't learn it. That's why I look so ignorant. It wasn't taught. So we need to make sure that we make enough noise that this is not forgotten. And then you create other channels to make sure that standardized education. So there is a strategic action in the area of training and medical education that you may like to work. An area of work is medicines that you need to do. Another area is to look at any other legal or ethical issues that are still our baggage, which is impeding our progress. There may be none, but I want you to apply your mind to this. There must be some, because somebody may see it as hastening, the end. I don't know. There may be some people who put professionals in this field to difficulty. So think whether that is an issue. If it is not, wonderful. If it is there, then you need to sort of, create a framework in which person who is going to be prescribing the medicines and engaging in this very sensitive discussion. And family dynamics always have some people who have their own axe to grind in a system. If there are none, I'm very happy, but it occurred to me that I flagged this issue. The last point that I wish to make to you is to create, advocacy, because in some ways you are like what neonatology was in the 80s. Nobody would think it's important. Although we realized by that time that 60% of infant mortality was neonatal, but people were not worried about it. We focused on diarrheal disease, at times pneumonia, vaccination. So I have seen that journey of some of us working very hard to bring newborn health center stage. And today it is an indicator for SDGs. It's being tracked as SDG indicator. And therefore there's a drive by itself. So I would urge you that a systematic advocacy, you are using this opportunity today in a way, but similar such opportunities and much more. So is there a palliative care day in the calendar of the nation? What noise did you make on that day? So we devised in 2000, when Honorable Atal Bihari Vajpayee ji was Prime Minister, we launched the first newborn health week, 2000. And we had it launched from the home of the Prime Minister, right? So that helped us. So you think about how you would bring visibility. And I think NGO community has a big role to play. We would like to hear more of such noise. There are multiple ways and you should debate. There are people who can guide you better than this. But remember one thing, advocacy which is based on data, evidence, truth, and information which is presented in compelling, emotive form, that works. Advocacy which is just for the sake of advocacy doesn't work. At least in health priorities, it does not work. And people who don't use this have missed it out. I'll give you an example. As I said, newborn health. So we made a case. We also then made a case that it can, simple things do work. From nobody accepting it, it became a mainstream discussion in MDGs. India was among the first to do it. And then the global community picked it up from us. And some of the reasons why, we are gains in India, in our own country, and then the world accepted. They thought that, this helped the cause. Somebody that started to talk beyond maternal health as newborn health, facility-based newborn, home-based newborn health. Now, newborn health as an indicator to be changed, and so on. So what the lesson that you have is that you make a case by offering data, unmet need, for example. Okay, human stories are fine, but then human stories are one-to-one, it doesn't change the policy. It is the data, information, and solution. So we talked about some solutions today: home, family, telehealth, this, that. What is it that I work with? I may be in a position to do one part of it, not the whole. But you have an opportunity to put it in the health and wellness center tomorrow, because it is listed as one of the 12. You can expedite. It need not be the last one. It could be the second last or the third last if you work hard on this. So solution, evidence, truth, and saying this repeatedly, but with different people, because people get fed up with the same voice. So done differently, different people, they'll help. Reach out to parliamentarians, reach out to the state government, reach out to private sector, and so on. There are multiple ways today. That cannot be the discussion. For this, we need to be together some other day, but you can do a lot of advocacy in this area, and the cancer health community knows this better than anybody else, because they have delivered on the ground, they have brought resources, they have provided help to lakhs and lakhs of underprivileged people by helping in multiple pathways. And today, cancer care in more than one way is mainstream. I mean, we are rising the cancer care aspects. It's part of PMJ. If it is palliative care packages are not part of PMJ, inpatient care, tell us. So think about where all this can help you with. With these words, I once again compliment you all for being there for a very, very special, humane, noble cause, noble mission. Compliment you for the work that you've already done, and compliment you for the the partnerships that you have developed with NGO community, with professionals and others, and you are building on that. And the journey is obviously not yet complete, but that's the fun of it, because you could be the one who changed this generation changed the course, would change the course of palliative care. And you can only take palliative care upwards. That's your opportunity. Thank you very much. Jai Hind.
Thank you,
Thank you,
Dr.
sir.
Paul. That was a very inspiring lecture you gave us. You shared your years of experience and wisdom with us. And I think one couldn't agree with you more. The words, we need integration from the lowest levels to the highest levels. We need to bring care closer and closer to where it's needed. That's at the home of the patient. And the family plays a very important role there. And I think your wish that models be created which use home-based palliative care integrated with the public health system, I think is very important. And I will give you an undertaking today that at Cancer Support, we are going to do this.
Ayurveda.
And include Ayurveda, yes.
At some point, and I can try to see, will help you with connecting with whether such options are there on that side and what they are. You will like to systematically examine them. Please do let me know if you need assistance on that.
We certainly shall. We have to deal with the reality that's out there and work with that and see how best we can close this gap in equity. So thank you very much. And I'd like to thank the other speakers too. And
us, and we will do it, sir. We will do it, sir. We'll come back to you. Thank you very much, sir. Anjum.
Thank you very much, sir. Thank you, Dr. Lal. Thank you, Dr. Paul. Thank you, Dr. Sushma. Thank you very much, Dr. Harmala. We close this session. We've learned from you, sir. We've taken notes. Thank you,
Thank you, sir, for giving your time, sir. We are really honored, sir. And
All
so
the
many-
best. Take
Thank
care.
you, sir.
Have a
Thank
good
you.
day.
Bye-bye. Bye-bye.